Hello, hello. I am Joe the Science Bro, and this is Science Talk. As we have been in the past, we are continuing with this interesting journey that we started back in January, where we are bringing on different experts in the scientific and medical fields to answer our questions and just have a nice little chat with us. So I want to introduce. He's kind of considered the prolific osteopathic manipulative therapist, and I'll let him explain why that is. But I would like to welcome to our show Dr. Alexander Nicholas.
Thank you, Joe. Thanks
Welcome.
for having me.
Thank you for accepting my invitation and joining us. If you could, just briefly, what is osteopathic manipulative therapy, and how is it different from just going to a chiropractor?
Oh, that could be a little bit long in the tooth explanation, but osteopathic manipulative treatment or therapy, we like to say treatment because therapy is more like physical therapy, so it has a slight different connotation. Is a hands-on, physician-applied technique to the patient to treat musculoskeletal problems such as arthritis, back pain, neck pain, migraine, headaches, things like that. However, in its beginnings, it was really a technique to treat general illnesses, so pneumonia, circulatory problems, infections. And then I guess for a period of maybe half a century or more, everybody thought it was musculoskeletal, back, neck, shoulder, things like that. So if you looked at my practice over the years, it's probably predominantly in order low back pain, neck, and shoulder girdle is the three top areas that we see. But I have patients that have GI issues, cardiac issues, pulmonary, and they sort of find their ways to us. But it's thought mostly as a musculoskeletal thing. The chiropractic osteopathic link is interesting because there are people in the school in Kirksville, Missouri, which was the first osteopathic medical school in the country, then known as the American School of Osteopathy. Think that Palmer, who started, D.D. Palmer started chiropractic, was actually a very short-lived student at Kirksville and left, and then went up to Iowa and started chiropractic and didn't think he needed to sit there and learn everything he could figure it out himself type thing. So those are the osteopathic rumors, whether it's true or not. I think the difference is that when Andrew Teller Still, who was a preceptorally trained physician in the Midwest, was disgruntled with medical care of his patients, and he thought there was a lot of heroic medicine being delivered, which was dangerous and caused a lot of bad side effects and even death. So if you go back to like President Zachary Taylor, who was an Indian War general and became president of the United States, he passed away in office, and probably about 15, 20 years or 20 plus years ago, historians wanted to exhume his body because they thought he might have been assassinated. And when they exhumed his body and tested him, he was indeed poisoned with a lot of high mercuric contented minerals, which were the things that the White House physicians were using to treat him. So basically, Zachary Taylor was iatrogenically killed by his White House physicians in the 1850s. So Andrew Taylor Still, right after that, was coming on saying there's too much of this heroic medicine, it's bad. And other people would say that. You can go back to Napoleon in the early 1800s talking about how it's better to throw all the fishes, give the fishes in the sea all the medicine, but it would be better for mankind but worse for the fishes. And other very famous physicians in the early 1900s were saying the same thing, but still actually removed himself from the allopathic profession. But he taught it as a physician-based practice, whereas chiropractic, Palmer was teaching it as a lay manipulation practice. And over the years, the techniques that Palmer used and DOs used early on were very similar, but after maybe the first 10 years or so of osteopathic medicine, they started adding other techniques to incorporate safer techniques that you could do for a more broad audience of patients, elderly patients, disabled patients, frail patients that couldn't tolerate some of the early techniques. So right now to the medical students here at PCOM, I think we teach them 12 styles of technique, osteopathic manipulative treatments.
Mhm.
Whereas when I was in school in the early 70s, I was taught maybe 2 to 3 styles
Mm.
of technique. So it's pretty, the technique armamentarium has
Yeah.
expanded by 4 in the last 40 some years.
You're expanding the war chest, if you will.
Yeah. Well, what you have in your little doctor's bag
Yeah.
that are your hands, but you carry your hands wherever you go.
Yep.
So if you're a DO that uses these techniques, and a lot of DOs don't, because they're in other areas of medicine, that
Mhm.
it's pretty practically impossible to be a cardiothoracic surgeon and then run around treating people with your hands as an osteopathic manipulative specialist as well.
Mm.
But it allows us to go into an ICU and treat somebody in a COVID unit,
Yeah.
versus going into having an emergency room physician. They have lots of people showing up with back, neck pain, headache, and instead of loading them up with a lot of meds, they can decrease the milligrams of the meds and add this and have a much safer, effective response.
So, with osteopathic therapy and treatment, are you noticing that the patients, at least in a clinical sense, are you noticing that the patients require less medical pain relief? So, meaning pharmaceutical pain relief?
Yeah.
Or is that more anecdotal information?
I think I prescribe a lot less. I don't know about my associates.
Mm-hmm.
The older I got, the more I wanted to be classically closer to still,
Mm.
to the earlier docs that just use their hands.
Yeah.
So most of my prescriptions are just careful over-the-counter anti-inflammatories and analgesics, and tell them to be really careful, because as odd as it seems, they may be some of the most dangerous drugs in
Mhm.
America, because they're over-the-counter
Yeah.
and patients don't know how to they'll just, I have a little bit of pain, if I take 2 more it's going to help, and because nobody's really following them,
Yeah.
they can wipe out their kidneys or their livers or their gut, and they don't realize they're doing it.
Yeah.
So I might, but I'm very careful about how I tell them to use those over the counters. And other than that, it's ice packs,
Mm.
sometimes heat, carefully, because heat's a little pro-inflammatory, I find.
Mm.
And ice tends to have a more safe anti-inflammatory, analgesic, almost anesthetic combination without the bad side effects.
Mm.
So if they can use just a little bit of over-the-counter med with a lot of ice, sometimes heat mixed in, and the manipulation, I haven't written a narcotic prescription in, I don't know, 7-8 years.
Wow. I myself am a recipient of osteopathic therapy, and one of the things I've found, especially among my colleagues, because biology has turned more into a sedentary trade now, is a lot of that lower back hunch, what did my doctor call it? The computer hunch, where you're just sitting there, just barely bending, and it's putting all of this extra trauma or tension on your lower back. And at least for me, I've my OMT, he prescribed me to go to physical therapy as well to help strengthen the core of the back, and I haven't had a spasm in a year. And when I did, it was nowhere near as intense as it was prior to the therapy.
Right.
So I can personally say that it has been a benefit to me, and I find it very interesting that you're seeing less and less use of the narcotic. Probably also because have you noticed this amongst your colleagues that it's more of a, with the given climate in the world, that you're less and less trying to, because of things like oxycodone and other narcotics and other opioids.
Right. I'm sure there are a lot of physicians that, because of the oversight of all this, are a little gun shy for prescribing as well.
Mm.
It's kind of interesting too, because the way we were taught to use narcotics, and some of the pharmacologists that would teach our students and give seminars on it, a lot of us were using it at the new science level of recommendations,
Yeah.
and all of a sudden it just changed like that.
Yeah.
Like, whoa, what happened? And yet, I've read studies that say that people who have surgery or trauma who do not have their pain eliminated rather successfully quickly and are lingering in pain and don't have it really taken down, like from a 9/10 down to like a 2. If they're still hovering at a 7 all the time and that pain is not being alleviated, they end up as the chronic pain people. And the people who are babies about pain, they have low pain threshold,
Yeah.
they bark and bark, they want the pain meds. They don't turn out to be the chronic pain people because they supplemented those signals going into your brain.
Right.
And it's almost like it's a biologic computer. And those signals that come in long enough, it's almost like hitting the save button. So if you can get that brain from receiving those signals, they have much less pain, post-op. Actually, one of the pharmacologists here, Dr. Fred Goldstein and I, and another, we had a research project after gynecologic surgery, and it showed that the patients did best with a preoperative dose of morphine sulfate and manipulation the afternoon after the surgery, and decreased their pain quite dramatically. And they did well, Actually, we lost a few people in the study who left the study and didn't want to stay in a hospital because they had no pain. So
see, that
it
was
worked
something.
too well. It's almost like you have to shut your project down because you were too successful.
So that was actually one of the things. We actually had Dr. Goldstein on as a guest, and he did mention that study. I find it so interesting because he didn't mention that he lost a few people in the study
Yeah, I
because
think
they
one or
had
two
no pain.
actually discharged themselves, and we couldn't do the
That's
full treatment.
that's fantastic.
So we weren't able to include them in the study.
Would you say that that's the best kind of outcome for the therapy, in a way?
Well, it's, and if you look at, I don't know about right to this date compared to when we were doing it, but when we did it, it was a little different about that preoperative morphine, and then it became actually common use. The anesthesiologist would just do it before the surgery because they found that to be helpful. But no one had ever matched that with manipulative treatment, post-operatively. And then the idea is also, you do it preoperatively and post-operatively to also get a better result than just do the morphine preoperative manipulation post-op. Maybe if you do the manipulation preoperatively as well. So there's a number of pain studies with manipulation. And it's interesting, as an American DO, I guess the American DOs, the American MDs, have a certain reference zone of articles they read. But if you leave America and you look at the international publications, what most people in America don't realize is, as DOs as well as MDs, once you leave America, there's thousands of physicians worldwide that use manipulative techniques.
Really?
And acupuncture and all sorts of alternatives. And I've been teaching in Austria, Europe, and Germany primarily since 1998. And we have an organization over there, which is the German American Academy of Osteopathy. And there's over I think there's 1,100 members right now in that group, and they're all allopathically trained physicians. And they come into our courses after they've already taken a musculoskeletal manipulative course in Germany or Austria. And that's what gets them into our courses, because they're learning techniques that were American osteopathic, chiropractic from, let's say, pre-World War II. And that's what got into Europe. And that's what they knew, but they didn't know all the new osteopathic techniques that were developed. So we have a PCM here in Philadelphia has a link with this group and a larger German teaching group. So I'm kind of the honorary lifetime president of that group, because I was there from the beginning using the PCOM. So I probably have more doctors in Germany and Austria that I'm friendly with than in America at this point, which is quite
Is there a
interesting
reason
to
for
me.
that? Like, is there a reason why in the States here it seems to be that we're more likely to go to a chiropractor or just to take an analgesic, while it seems as though in Europe it's a completely different ideal?
Yeah, I think in Europe what you have is you have MDs and you have non-physician osteopaths that are largely physical therapists that learned some of our techniques previously.
Yeah.
So that now the physicians wanted to learn it. So there was a little bit of a tug and war in Europe between the therapists and the physicians. And then you have a group of chiropractors that, because of the physicians doing it and the osteopaths, non-physicians doing it, that the chiropractors like the minority group now. And since there's such a larger group of physicians and physical therapists doing something osteopathic in terms of manual technique,
Yeah.
the chiropractors aren't as popular over there now. Here it's MD, DO, and the chiropractor.
Yeah.
Most MDs don't do too much in the manipulative field, but so many DOs, because we're physicians, they get to medical school and they say, oh, I want to be a dermatologist, I want to be
Yeah.
a psychiatrist, I want to be a radiologist. So there's a few fields right off the top of my head.
Yeah.
But there is no hands-on really care of the patient in that respect of manipulative medicine. So now if somebody's looking for manipulation, there's a lot more chiropractors, because 100% of the chiropractors are doing manipulative medicine, where only 7 to 10% of the DOs actually are doing it frequently.
Yeah. So, what would you recommend, in terms of seeking out osteopathic manipulative therapy? If someone has this level of chronic pain, that they're taking these analgesics regularly, would it be something that you would recommend that they at least attempt osteopathic manipulative therapy before seeking,
Sure.
let's say, chiropractic or intense physical therapy?
Yeah, they could probably just, if they're interested, one of the easiest way to go is to go to your primary care physician and say, what do you think about manipulative treatment in osteopathic or even chiropractic? Is it helpful? And we have actually some of our largest referring group are MDs and MD physiatrists,
Really?
physical medicine, rehab docs. We have a pretty good relationship, especially here at PCM, with a number of them in the area that are interested in it. They just never were trained in it. And we have, we just share our, a lot of them are doing like epidural steroids, intrafacet injections, other physical therapy modalities, and then they send to us for the manipulation. So yeah, primary care docs usually in the area know who's doing the manipulation. If not, from an osteopathic, you can always go to the American Academy of Osteopathy, look up their website, and you can. There's probably something there that says find a DO that's a member, because all the members of that academy do manipulation, and you just put in your address and your state, and they might be able to find somebody for you.
I have I've been the beneficiary of DO doctors for many a year. My first doctor was an MD, but he was more of the family MD type. And then after that, I guess it was just due to insurance networks, my family just seemed to keep going to a DO. And I always found that personal touch in a DO was much more beneficial to me. And it seemed as though they wanted to, for lack of a better term, actually put their hands on me to get the feeling of what's going on, rather than just hearing my symptoms and attempting to diagnose the problem. Do you think that that's one of the major differences between an MD and a DO, or is it more training? Is it more thought process? Because I know that there's kind of a weird relationship between MDs and DOs in the United States. Could you actually describe what a DO is for us?
Yeah, it is kind of interesting. Like I could go back to like the late 1970s, and my next door neighbor was an MD. Next door neighbor on the other side was an MD, and the other neighbor was an MD. And we moved into the house, and I went to work that day, and I came home, and my wife said, "Oh, I met Dr. So-and-so 2 doors down, and she saw and talked to me, and she asked what I did, what my husband did." And I said, "Oh, he's a physician." She said, "Where?" And I said, "Oh, down the street at PCOM." And she goes, "Oh my God, your husband's a DO?" She says, "Yeah, wait till I tell Tom." And he was a hematologist oncologist.
Oh.
She said, "I don't know if it was good or bad, but So the next couple days later in the week, I'm out doing something, and he walks up and he goes, "Dr. Nicholas," and I said, "Oh," he introduced himself to me, and he goes, "I do lecture at your medical school once in a while in the Department of Physiology and Hematology Oncology." He was friendly with our former chief of physiology and pharmacology. He said, "Your students are like great, and the ones I have in my office are so good." And he said, and the last one just married my secretary. Now I'm going to find a new secretary. He goes, what is it that you're doing? Why are they better than the other students I'm getting at this major hospital? And I looked at him, I said, I have no idea why. I said, I can guess at it because I'm on our admissions committee.
Yeah.
I said, we tend to look more at humanities as majors. We do, most of our majors are from bio and chemistry and some psychology. I said, but we're looking for people that have other humanity aspects to them. If it wasn't, I was a general arts and science major in college. I wasn't a science major, so all my electives were science courses to get my prerequisites made for medical school. But I was probably 3 credits shy of being a history major. So I was kind of the humanities person, which probably put me behind the 8 ball in medical school because I was competing with all the science people, and that they had many more science credits than I did coming to medical school. But on the other hand, I played sports, and I, other, like my department members, probably 3 out of the 7 are musicians, singers, artists. It's very humanities oriented in my field. And medicine in general, had been more science oriented.
Yeah.
So the applicants tend to be athletes, artists, musicians, as also with the science. So you get people maybe with a slightly different social background. I think I learned this from my cousin up in Boston. One of my cousins, a cousin of mine, was former chief of neurosurgery at Harvard and Mass General. And he would always send us, my other cousins, to certain doctors that were just special. They might not be the chief or anything like him. And one of them was head of cardiology at one of the major hospitals. And they were talking, and he said, how are you so personable? All these other doctors I meet here, they're all so stuck up and they act high and mighty, and they think they're so great at Harvard and there. And he goes, well, he said, I surround myself with residents and people in my area where I accept them to work with me or become my residents. And I always ask one question of them. Of all the other questions, this might be the most important because everything else is on paper. Their grades, their undergraduate medical grades, their national board grades. And after they look like they're sane and they're civil, I'll say, have you ever waited tables down in Cape Cod in the summer? And the ones that say, oh yeah, I've done that all 3 years, those are the ones I bring in for my residency because they can deal with the people, they can deal with nice people that are grumpy, people that want to send their food back, and they rush around and they can take that hectic and still be friendly and still get their tip. And I know, okay, they'll be fine in my department. They know how to work when it's rough, and they know how to work with the rest of society. They haven't sat behind a lab desk for 3 years helping some famous scientist trying to get his Nobel Prize. And so that's kind of what we do here. We're looking for those types of applicants that might not be the classic memorizing science geek. It's not really a good word, but they have many other non-science attributes. And the fact that they take the course that I chair, which is hands-on from day one, totally strange freshman student paired with another strange who they don't know each other, they're total strangers, and they have to stand there with their shirts off and shorts on, looking at each other and picking out all their asymmetries and imperfections, which breaks your physical barrier down pretty quickly. And you start to get used to touching each other after looking at them, and you're touching and touching for 2 years into third year. And so now you don't have a physical barrier. And now you're not afraid to touch a patient, and you're a little more hands-on. That doesn't mean like the MDs aren't either. My family doc for years was an MD who was, for all intents and purposes, he acted just like my really good DOs, colleagues. It's just that we're just looking for that slightly different kind of student, students that had a lot of other extracurricular, activities. They're not just trying to get that 3.9, magna cum laude, summa cum laude. They're doing other things. They went to a couple of fraternity parties maybe. They did go to the football games because I've interviewed students that I never went to the football game. No, never went to a movie. No, I didn't go to parties. Would you go back to that college? Yeah, I think I would because I think I learned a lot. And I said, but your alumni department is not really interested in the way you're answering all these questions.
Yeah.
You know, you go to like a big school like Penn State. Oh, you got to go to Penn State. It's great. You know,
Yep.
oh, it's great. Some of these other schools that are pre-med factories, they don't sound like that. Those students. You know, whereas if you're at the same school but you're in a marketing major,
Yeah.
you had a good time. It was great.
Yeah.
The school was fine. But certain majors, you know, like medicine, well, they want to look really good statistically.
Yeah.
So they might have 200 pre-med kids starting out, and they only finish with 45. But 99% get accepted to medical school.
Yep.
Because the others are now in another major now.
That's correct.
So we have slightly different, but it's just, I think it's just there's a sociologic nuance in
It's a
terms
different
of
mindset.
who we accept, and then the fact that they're just forced, and some of them don't like it. They're like, wait a minute, and you're like, well, you knew what the school was. You saw all the videos. You had the tour of our lab with our students already in there. What didn't you get? And they still like, and by the second year, they're all like on top of each other, pulling,
Yep.
and they're broken, and that barrier is broken down, and they will act differently from then on. And it's just a matter of, you know, now you have a nice general surgeon that, you know, is touchy with you and
Yeah.
puts his hand on, and you know, we do teach them too how to palpate and
Yeah.
how to make contact with people. Are you palpating something to gain information, or are you touching them to give them information? Like, I'm empathizing with your situation.
Right.
I'm comforting you. Versus, this tissue is abnormal. I have to take it here.
Yeah.
So you're getting a couple. So they're taught how to do both, and also to stay out of trouble with human touch. Because
Right.
you know, some people still have their physical barriers, even though you might have had yours broken down in medical
Well,
school.
you know, it's interesting that you say that because the chat has been going as you've been talking, and one of the things that was brought up was, you know, why doctors are so hands-on when talking, but they clarified saying, you know, while they're talking to them, they're patting their knee or their hand or their shoulder, and that's like, it's like, why are you doing this? Why are you touching me? And I think that's what you're getting at, is that there's certain levels here, and some don't realize that they might be trying to empathize, but really it's not coming across that
Yeah,
way whatsoever.
Sometimes it can be a little condescending too.
Yeah.
Yeah. So we specifically do try to teach our students how to interact with patients, so that you sound sincere and you do it in a proper manner that doesn't put you and the patient in an odd situation.
Yeah.
But I have patients that are referred to me, and yet they still don't know what I do. and I'm doing what I've been doing for 48 years. So like, okay, why don't you lie down here? And I just start, and I'm like, ooh, they don't even know what I'm supposed to. So I back off. Do you know what I do? Like, do you have any idea what's going to happen here? Because it could be like, oops, you know, yeah. And you know, and COVID made it a little more difficult because they can't see it. They can see my hair's all dented from my mask all day and stuff, and they don't even know what I look like. And every once in a while, my patients from years and years that I'll see, I'll pull my mask down. Hey, see my COVID beard?
Yes.
And I put it back up. Oh my God, you have a beard.
I looked because, you know, we couldn't get our hair cut or our beard trimmed or anything like that. And to be complete, for those of us that are old enough to remember, I looked like Grizzly Adams at a certain point. And I took a picture before, and then I went to get my hair cut and beard trimmed, and I looked like a completely different human being afterwards. I was the man out of the mountain, and then I looked like I had just come from an office. So let me ask you this: why medicine, first of all?
Well, I was kidding around with you earlier.
Yeah.
But I was serious. There were a couple things I wanted to do, and I didn't have a voice for singing, so that was out. And my baseball career didn't work. And there already was a Jacques Cousteau. They didn't need another Jacques Cousteau because I was really interested in marine biology. So I was an internationally certified scuba medic at 15 years old.
Okay.
So that was 1964. Not too many people in Philadelphia scuba diving in 1964. So I was really going that way. But when I went to, my father was a physician and my cousin was a physician, and you know, so I had that. So listening to people talk about these physicians, they were talking about them in a different way than they would talk about the good accountant down the street or the guy that owned the 2 gas stations that was in Rotary Club with him or this and that. And my father had patients come to the house a lot and did a lot of house calls, and I would go with him and I'd see the people that came into the home. And the way they responded to his treatment of them and what they, oh my God, your father's Dr. Nicholas? Oh, your dad saved my life. And I didn't see my classmates in high school and having anybody talk about their parents that way.
Yeah.
So then I said, well, if I went into business or I did that or I did that, doesn't seem really like I'm doing much for anybody other than myself. Like, just it's kind of nice to have people talk about you that way.
Yeah.
Like, and to just give yourself to society and have them just really be so appreciative. So I said, okay, maybe I can do this. And my mother's best friend, who was my aunt, who was like a second mother to me, she always told me I had to be a physician because I was supposed to take care of her as she got older. So I had that in my brain.
Mm-hmm.
Never came from my parents. My father just, whatever you want to do. But my aunt had that, we got to take care of me, got to take care of me. And the more I went with my education, I said, well, if I do anything and work with porpoises and dolphins, and I'm going to have to get a PhD before I even get to do that.
Mm-hmm.
And then I'm going to have a research that gets approved, that gets me some money. And if I don't get reapproved, I have to put my porpoise somewhere. Who's going to take care of my bottlenose dolphin? And so I just kept heading toward medicine. And, like I said, I was also pretty good in baseball, and that didn't work. So I went, let's give it a shot. But like I said, I had the prerequisites to apply to medical school.
Yeah.
But I probably had 30% less credits in science than my classmates did. So I just needed to get past the science. And as a practitioner, I've always argued with a lot of the basic science PhDs saying, I think, you're giving them too much information early. Most family docs don't need to know science at this depth. I said they need to be able to talk to a person, listen to what they say, palpate the person, do your physical diagnosis, and kind of be Sherlock Holmes and say, well, they walked across the field and they did this, and it was a rainy day, and they bent over and they picked up a couple of sunflowers, and that's probably what did it. And then they redid this over there, and I don't need what the Krebs cycle is. I don't need to know.
Why do you bring that up?
I just don't
the
have
pain.
to do it. Now, if you're a doctor and or PhD or a physician PhD, and you're trying to find medicinal cures and other things like that for people's illnesses, you need to know those physiologic prospects or processes. But as someone is saying, okay, you have a patient with diabetes mellitus. Okay, I see your sugar, I see your blood work. Okay, we have to do this. But I don't need to know all about it to the point where I'm going to develop the drug for you. Those are the people that need to know it. I just need to be able to put people in syndrome categories and then find night to the number 1 or number 2, identify the top 2. And with the osteopathic manipulative treatment, the diagnosis I'm trying to come up with is called somatic dysfunction.
Right.
So I'm trying to find someone that might have migraine headache. That might be the first, and it might be migraine number 1, cervicogenic headache number 2, and associated with that they have cranial and cervical and upper thoracic somatic dysfunction that's causing it to be more insidiously developing and then acutely and more painful and more frequent. So if I can allay the secondary tangential problem, somatic dysfunction, the more centralized problem, physiologic problems causing the migraine or the headache dissipates, and now it's, instead of an 8/10 pounding headache where they can't do anything for days, now it's a 4 and they need less medication. And eventually, if I can get that secondary somatic dysfunction, that tangential problem eliminated, their headaches might be like 60% reduced.
One of the things that I've always likened to DOs, at least in my experience from MDs, is most of the time whenever I've come in contact with an MD, it's usually what pharmaceutical or what drug or what therapy am I giving you to take care of the symptom, while every DO that I've ever had has tried to find the causative agent of what is actually causing the symptom rather than just trying to mitigate the symptom. Part of that is probably because they've come from this institution. It's very common for where I live in South Jersey that if you have a DO, they probably came from here. And in fact, my family doctor right now is a graduate from here. Very good man. And one of the things that I've always found is that his way of interacting with me, his way of he doesn't have to explain things in the same depth to my mother that he would with me. My mother needs a lot more layman explanation. He can, relate things in a scientific method for me, and I'll understand what he's talking about. He and I have a common language that we can speak together. And I think that that's kind of one of the things that is missing from modern medicine a little bit is, like you said, it's that, in a way, that personal connection, that way that you're linking with the patient, you're empathizing with that patient, no matter what their symptomology is. And now that I'm mentioning sympathy, it makes me think of Disorderly Orderly with Jerry Lewis, where he would physically display the pain of the patient. But I almost wonder if breaking down that physical barrier is the main, piece that allows the patient to suddenly, put away their own bias and focus solely on the patient.
I think it's one of the more paramount aspects, obviously. It is interesting that if you look at our fourth year medical students that rotate with us, that choose to rotate with us, and you look at their backgrounds compared to the general population, they all have these other aspects of athletes, artists, musicians, the humanities, literature, polyglots, multilingual, things. They're just a little different than you'd expect from a very science-oriented person. Although if you go back to a couple of our student entertainment follies that we used to have, a large number of the PhDs here have a pretty good band that they have. So so it's not just, but there's it's a applicant pool that's slightly different. Their science grades probably aren't like at the 4.0. They're doing other things. So since they're so obviously interested in other things, they can't just
it's something that my father used to say to me, because my father was a history teacher for 20 years, and he always believed that just because you pull one item from history or one moment from history, there's so much else that goes into that. You can't just say, oh, well, this is what caused World War II. No, there's like 15 other things that went into that before you could even get to the beginning of that. He used to always say, a jack of all trades is a master of none, but a master of none is better than just a master of one. And as a scientist, personally, I've always tried to link, and maybe it's because of my own background, I'm a bioinformatician, I've always tried to link different topics together because no one thing in the body is isolated from another. So just because I look at DNA evolution, I have to think about what the environmental change was that caused that internal manipulation. So you and I were talking about the environment before we jumped on stream, and that makes me wonder, why did those changes occur? Is it because of a change in temperature? Or was it because of a change of the food? I work with Dr. Adams a lot, and he's actually an anthropologist, so he and I have very different ways of looking at things, and we actually use that to kind of enhance the work that we do. I do actually have a question from one of our audience members. It might be something that you might not want to answer, but if your students in your courses are all physically intimate in the way that you described, for professional reasons, it makes sense, but how often do you find that those students that are partnered up together end up joining in a relationship or develop romantic entanglements with each other, if you will.
Pretty rare.
Really?
You'll see students that date each other. So my daughter was a student here. Her husband was a student in her section, but they never worked together. I know other students that are married, but they're in totally different sections. It wasn't, I think I know one, I remember one student, I guess back, they graduated in probably the 1990, 91, something like that. And she was really annoyed with him in the first couple of labs, because he said, can I palpate this? Can I palpate that? And he was always trying to palpate her. And she thought that he was being fresh. But he had transferred from another medical school and had already had the course and was repeating it here. And by the third year, they were engaged. So that was the only one I ever saw. And usually they're pretty, the whole thing is to not be that way in class. You're trying to be as professional as you're taking a group of non-professional lay people,
right,
trying to put them in a situation where, the thing about being a physician, and I tell this to students, you're going into a profession where probably other than a priest or a lawyer can hear things that other people can't, but you can go further in your questioning than they can, and you can look at every part of their body inside and out, and you have to be ultimately a physician when you do that. You have to, if you're looking at somebody who thinks attractive on the street, that's one thing, but you walk into a waiting room, no one's attractive. No one catches your eye. No one makes you even go there. It's just, as soon as you take that patient back, they're a human body with a personality that you're going to try to care for, and all that goes away. And you just do that over and over and over. And doctors are, for the most part, they've grown out of the mystique of a body and an aesthetic allure. It's just like they've seen bodies, this shoulder, this breast, this genital. It's just the same. It's over with.
My wife, she's an artist. She actually went to Moore in Philadelphia.
So was my wife.
And it's funny how that happens. I know a lot of scientists and researchers and doctors that actually are either related to or are married to someone in the arts. But she told me, she's like, listen, bodies are just things to me at this point, because when she had to do life drawing, she had to do nude life drawing. And there was a joke on a cartoon where one of the people went, do I draw the penis? And my wife started laughing. I'm like, I mean, I know it's funny, but I don't think it's that funny. She said, no, that's an actual thing that happens in the classroom.
It's pretty. I was in Florence, Italy, and I was being given a personal tour with my wife and I by this archaeologist who was originally from Germany. And so we went in, and there's the David.
Yep.
And she said, well, you're a physician, right? And I said, yes. She says, well, look at that body and tell me if something doesn't make sense, something that's off. So I stood there and I looked at the David, and I'm like looking at her going, are you serious? You really want me to say this? And I said, I think I know. She goes, the hand, right? The hands are too big. Michelangelo was trying to show this little guy had a hand that he could throw that stone at Goliath. And I was like, oh, okay. She goes, what? I said, I wasn't thinking of the hand. She said, well, what were you saying? I said, well, as far as I know, David was a Hebrew, and in that period of world, my history might be wrong, but weren't they circumcised?
Yep.
I don't think he's circumcised.
He's not.
And she went, oh my God. Different perspectives.
What was it? Because my wife is an artist, she got to hear some of the history behind art. Did you know that Michelangelo couldn't draw a female breast to save his life? What he actually would do is he would take men and he would hang oranges and tape them with plaster tape to their chest. And that's why if you look at his females, the breasts look so horrid, and they are absolutely anatomically incorrect. And that's the main reason, is because
Just couldn't do it.
I mean, he was a student in the same way that Da Vinci was. You grab cadavers. Well, what's one of the first things that goes away in cadavers is the fat and mucosal tissues. So you weren't going to get a good look at one. That's why a lot of people believe that he was gay. Actually, I think the current feeling is that he was asexual.
Could be.
One of our audience members actually is incredibly curious of what your morning routine is.
My morning routine
Yeah.
at work or at home? I get up early and take a shower, shave, and make my wife coffee, feed the dog, and drive 50 minutes to work. And
I know that
I'm
feeling.
actually, I might seem like I'm a pretty outward guy.
Mm-hmm.
A lot of my students think I'm a super extrovert. I'm actually the rarest of personality traits, according to Myers-Briggs, if you believe it. One of my students forced me to do it because she said, "You're not an introvert." I said, "Yes, I am." I said, "I need to get out and be by myself, otherwise I go crazy."
I know that
so,
feeling.
I come in, I'm quiet in the car, I listen to classical radio, and now because I'm a big NFL Philadelphia Eagles fan, I've been listening to the draft, so I'm back and forth between the sports talk and the classical radio station. And just as I walk into my medical office building, I go, "Okay, Alex Nicholas, chairman of OMM, PCOM, take one." And I come in there, "Hi, how you doing?" Boom, 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 boom. At the end of the day, I leave. Bum, da-dum, da-dum. Quiet, quiet, quiet. And I have medical students there. Say good. In my department, we're pretty multifaceted. So I come in and I say, "Buenos dias" to one secretary. I say "buongiorno" to the other doctor and the other secretary. My associate that teaches in Germany a lot for me, that's a polyglot, I say "Guten Morgen," "Kalimera," and I usually say good morning in 3 or 4 different languages.
Wow.
Even though I only know like 1 and a half. But I know how to say good morning in French and Italian and Greek and German. And then I have students. And I'll talk to the students, "Okay, it looks like we're seeing these patients this morning, da-da-da-da. You want to bring the first one back? It's so-and-so, Mr. and Miss so-and-so. And they have this," and then get some information, and I'll be in about 5 to 10 minutes, and we start, and we go from patient to patient till the end of the day.
Wow. Do
my electronic record on my computer, which I hate, and it was a lot nicer when I could just write my stuff down.
Do you think that it's I'm interested in these opinions because the future is going to be digital for a lot of things. What do you think about the proliferation of the digital chart?
I don't like it.
Mm-hmm.
A lot of physicians don't like it.
Yeah.
If you're in a multi-specialty group or a big hospital that the physicians in the hospital share the many patients, and then because of hospital floors and stuff, nurses are putting information, et cetera, in, the charts are more readable, for sure. But if you're in a small 5-7 group, we don't share too many of our patients. I don't have an external system I'm related with.
Yeah.
For 95% of the time, my chart is just for me.
Yeah.
And I can read my own handwriting quite well. And what the electronic record does too, because of insurance companies and third-party billers, they're now more insistent upon having the note.
Yeah.
The note has to have this and this and this and this, and if you don't have all that information in for every single visit, you can't charge for it or charge this level. So now you're forced to put more information every time. And I mean, if you had seen my father's and my mentor's charts from like 1968,
what was it, 1 line per visit?
It was a date, a blood pressure, and $5. That's what it was. And they practiced for 40 years and didn't seem to have any problems. And they knew all their patients by name. They knew the whole family.
I have always said the insurance companies, at least in their current state, is one of the reasons why we have so many issues with the American health system. But I won't bring out that soapbox. We'll be here for a year and a half. Yeah. One of the reasons why I think digital charts might be a good thing, or at least there's a benefit to it, is if we ever at some point had a centralized record system where the primary care physician or the specialist chart could then, in the event of an emergency, be given to the ER doctor or the
Sure.
internal medicine doctor. That's the only benefit that I've really seen. But like you said, if you're just a primary care physician and it doesn't go outside of your office, I see my doctor, he takes it with, by hand, and he teaches all of his students by hand. And I think it's fine. Because there's okay. One of our audience members, they like their chart because the digital chart also is available to them, and they're able to see it. He was sent to an urgent care visit and sent to an orthopedist and to the MRI lab, and it's all in one place that he can actually view it.
The only problem I've seen with it, which is an odd problem, and I've seen this with friends, family, and my wife, and some employees with like serious medical conditions where they're concerned that this could be cancer, tumor, or something. They'll be sent for testing, and before their attending physician ever gets to read it and discuss it with them, 6 hours later they're reading all about their problem, and they're not reading it correctly, and now they think they're going to die of cancer. And now they're trying to call the doctor, and the doctor's in surgery. Doctor can't talk to them until the next day, and for 15 hours they're ready to like have a hissy fit, and all of a sudden, no, that's how it's always been. It's just they're just reporting everything, and it doesn't sound that well to you. So that's the only problem that way that I see. But for just me, it's added. I mean, I could see 6 patients. That will add 1 hour to my day, unless I have my medical students helping. So if I'm all by myself and I see for every 6 patients, that's an extra hour that I'm in the office that I wouldn't have had. So now if I see 12 patients a day,
2 hours.
that's 2 hours. If I'm a family doc, has the same issue, and I'm seeing 25 patients a day, that could be 3 hours or more a day that you're playing around with a computer.
Exactly.
And I'm supposed to be treating the patient. So you do have these other benefits, but now you can't get in to see your doctor.
Correct.
My patients are waiting 6 months to see certain specialists.
That's
I get in trouble here if my patient, they tell the dean, or my bosses, I had to wait 3 weeks to see them. You guys are waiting 3 weeks to see you. I said, do you realize you can't get to see this dermatologist for 6 months?
Exactly.
It's really tough.
One of the things that I enjoy about charts these days is, yes, you do have it readily available, but my wife loves to make the joke that if you go onto WebMD or any of those websites and you type in your symptomology, you're either pregnant, you have cancer, or you're dead. And that's the joke, because, and I made this statement to my mother because my father was very ill back in 2018, and he actually passed away from mantle cell lymphoma, which, as I've understood it since he had it, is very insidious. It's only discovered usually in stage 4+, and usually kills very quickly. And I believe it's got a 10% survivability rate, and that's only for 10 to 12 years if you're lucky. The average life expectancy post-treatment is about 5 to 7. So when I was sitting there reading his chart after we were moving to a different hospital, everything I'm reading, because my parents were like, are they doing everything that they can? And I'm reading it, and I'm like, yeah, there's, and I tell my wife there's a certain, and she tells me because she sees it now that we've been together for 10 years, she sees it. There's a clinical aspect to my brain that takes over when I'm in work mode. And it's almost like my emotion when I'm dealing with that goes away. And it really is, you're reading between the line of the word that's written there rather than just the words that are sitting on their page. Yes, one of our audience members is a nurse, and as she puts in here, and I have to echo it as well, you always have to advocate for your own health, even if your doctor does not.
I always say I've been a patient, way more than I'd like to be a patient. And I have patients that come in to see me. Well, you doctors don't understand. You should have a problem. And after I said, I got to keep my mouth shut because I've had like 3 near-death experiences where I've almost been iatrogenically killed. And I said, talking to the wrong doctor. And I said, you need a patient. Everybody needs a patient advocate. And I must say to your nurse online there that I had nurses actually save my lives.
Yeah.
And the doctors are trying to kill me.
Yep.
Yeah.
I've observed myself over the years that nurses, especially in hospitals these days, they seem to be practicing the medicine way more than the internal medicine doctors are. They're practicing it almost from a theoretical standpoint, while the nurses are practicing it from a practical aspect, which, from what I understand, 40, 50 years ago was not the case.
Right.
But then again, there was also way more people in the workforce.
And you see the nurses on the computers too now outside
Yep.
everybody's rooms.
Yeah, and they're starting to get hit with way more of the digital work as well. You don't know how many times I've stopped a doctor from hurting a patient by accident. Most doctors these days, I think they see an average of 30 to 40 patients in a hospital per day, I think is what it is.
Is it? Wow.
It's something around there. I remember that it was a very
That's-
astronomical
yeah.
number that it came out to, that they maybe have 4 to 5 minutes per patient.
Yeah,
If that.
I'm unaware of that statistic, but I know outpatient, the average visit is between 8 and 12 minutes.
Yeah.
And I don't know, like, statistically if I'm correct,
Mm-hmm.
but it seems like there are so many medical systems out there now
Yeah.
that are operating and buying all the doctors' practices, that it isn't the physicians generating the rules that you have
Yeah.
to see. It's business people telling them that they have to see a patient every 8 to 12 minutes. A lot of doctors at a certain age, they just burn out doing that.
Yeah.
And they quit. And there are a lot of doctors retired early.
Mhm.
I'm trying to work for another couple of years if I can, and I have students that have retired.
Yeah. There's the interesting thing that I saw from the pandemic, and I'm always very sorry to bring it up to every doctor, because it's it was so much more difficult for you as a practicing doctor and a medical practitioner during it than was for me as a scientist. For me, it was a very interesting exercise in the application of the scientific process. But for doctors and nurses,
Yeah, if you were a hospital doctor or
Oh,
a hospital
God.
nurse, it was really bad. And then the private docs that were doing outpatient, a dentist, etc., they had to close their practices down for a
Yeah.
while. Like, luckily, I work for the medical school,
Mhm.
and the medical school kept most of us working.
Yeah.
Whether it was we had to, because we teach, so
Mhm.
we have like 3 hours of virtual class a day and things like that. So I was able to keep busy at home for 5 months, which made my wife realize I could retire. She never thought I could. And now then she told my daughter, and so, well, when are you going to retire? And I said, why does everybody want me to retire? Is there a rule that I have to retire? I said I had very bad mentors that died at 92,
Yep.
88, 83, and they were working. So I still have years to go, I thought. I said, and I do have a lot of hobbies, and I keep busy on the weekends.
No,
I
that's
said, but I don't
important.
know if my hobbies will keep me going 7 days a week, all day long. So I think, so it is kind of funny that everybody had such different
Yeah.
reactions. One of my associates, because we were on, she said, I hate to say this, but that was really a good 5 months. I was home. I got to see my kids. I got to cook dinner. I saved all this gas money.
Yep.
I was off the road, and I said, yeah, it was kind of it was a little different break. It was different. It was like if you were an intensive care nurse,
Mhm.
it was like they put you in a recovery room for a month.
Yeah.
Got out of that high, and you kind of whoop, and then you went back and you were sort of regenerated a little bit.
Yep.
However, coming back to work for those of us that were out, and you had to wear N95 masks and face shields and wash
Yep.
your hands and gloves and spraying the tables, and
Mhm.
oh my God, it was like an out of body experience when I didn't know what to do when I first came in, and the
Yeah.
patients were all like kind of nervous,
Jittery
and
and wary of actually being physically
and
touched.
some of them had some PTSD from it, and they were different, and it was I just walked in, had a mask on, and looked at my class. There's 75 people in there, and nobody's wearing a mask.
Yeah.
And I was like, wow, we've come a long way.
Well, one of the things that I to a certain extent, I am an idealist, but I like to temper it with realism when I can. I would love to see us learn from this entire experience as a society. Sadly, it doesn't look like we are. I'm already seeing people. I saw one person in Wawa the other day. The best way I can describe it is they were hacking up a lung, and I almost went, did we really forget everything that we went through over the past 3 years? You know, in Asia, in Southeast Asia, they almost wear armbands to show that they're sick. You always see people. It was norm before the pandemic that you'd see people wear masks because they were trying to keep other people safe.
I'd be in Frankfurt Airport because I was going to Europe
Mm-hmm.
to teach in Austria, Germany 4 times a year, and Frankfurt was one of my major go-through hospitals, airports, and I'd be at this one area where there was a restaurant and there was a shop and it was easy to watch the gates and where I was supposed to get my next flight, and a flight would come in with people from Japan, China,
Yep.
whatever, and you'd see, and a lot of them were high school age kids, and I'd get shocked when I saw one of them without a mask.
Yeah.
They all had masks on, and this was 15, 20 years ago.
Yep.
I'm like, and it's just I think it's just when the population and urban population housing is so close together, they know that viruses and things spread, and they just don't want it to go through the community.
It spreads like wildfire.
Yeah, and they just know, so they do it.
Yep.
And it's kind of interesting that when people say the mask didn't work, mask didn't work. Oh, now mask did work. You start to look at, well, something between masks and socially keeping
Yep.
apart. There wasn't any flu.
Yes.
Everyone was worried about COVID, but there was no flu.
You're exactly right. You are exactly right. I remember getting the report because I have connections in CDC and one of the virology societies that it was the lowest reported year of allergies, colds, flus, and pneumonia that they've ever seen. Ever.
It's crazy. Yeah.
And I think there was also, I think they saw that there was increased lung capacity for certain urban areas.
Yeah. It's funny how different people just took it so different. Like, I have a right to breathe.
Well,
it's a shame all the surgeons are associating in the ORs. It's like, really, seriously? And it just sort of like, I don't know. I have patients today, they didn't get vaccinated, didn't use masks. I said, if the mask is in let's say a 20-minute interaction with someone,
mm-hmm.
if you're wearing a mask and the other person isn't, you might have 15, 20 minutes that it's protective in an N95 mask situation. But if both of you are wearing an N95, you could be together for 40-some minutes.
Yep.
So I'm not in a room for 45 minutes, typically with an average new a return patient.
Yep.
New patients, it's an hour. But I try to keep the door open. People want to close the door. I can't open the windows because I'm in a modern building.
Right.
So I'm like, wow. And, reports of, like early 1900s Great Britain,
Yep.
and all the factories and industry, that London was a cloud. It was like Beijing. It was terrible. And people realized in the countryside that if we open the windows in our public schools, we might not get sick as much.
Possible.
And guess what happened?
Yeah.
They didn't get sick as much. So I'm like, all right, wear the mask. Maybe it's 5 to 10%. Stay away from the person. And people, why do you have to stay away from? I said, well, did you ever see somebody take a puff of a cigarette or a cigar?
Oh, yeah.
And then exhale on a quiet day? Watch how far that smoke goes. Then tell me, do you want to be 4 feet away from that person or 20 feet away from that person?
It was, what was the show? It was on Discovery Channel, Mythbusters. They did an experiment where they showed the cloud that came off when you sneezed. And they measured how fast it goes. And I think it's 40 some odd miles per hour is some of the particles that come out. And it goes fast, and it's a wide spread.
Yeah, and if the particles are small enough,
mm-hmm.
they're just going to keep going.
Yep.
And I'm like, well, so, it's just people, the science, all you can do is say the scientists are intelligent, ethical people on the whole.
Yeah.
This is what they know up to this point. They could be wrong because they're still going to be studying it.
Yeah.
But all I can do is do what they're telling me to do now.
Exactly.
Whereas if I just have this this belief in me that everything's wrong. And then the scientists 4 years from now say, guess what? You were right.
Mhm.
See, I was right. Well, you were right because you were lucky.
Yes.
You're not right because you were smart.
I have to echo this from our nurse audience member. My favorite is when they are wearing a mask but remove it to sneeze or cough. I've seen that too.
2 patients today had their masks right here,
Yep.
below their mouth. Usually, like, there was a theory I had kidding around. The mask on the regular patient, anyone from 70 to 80 was here.
No.
And then there was some that, like this young kid, college kid, 19 years old, who was here.
Oh God.
So the college kids are, they're nothing's going to bother them. They'll plug along, but it's still out there. My office manager just lost a husband and a brother-in-law a month and a half ago, within a week.
I had it just this past month. I had it for the second time.
But they died.
Yeah.
And I'm like, okay, people are getting it.
Yep. They're still getting it, and people are still dying from it.
And the vaccines are, vaccines don't keep you from getting COVID.
No.
They keep you from getting on a ventilator.
Yes.
And that's what most people have to understand. That's
Yes.
where it is. And can you get a reaction from a vaccine? Oh yeah, there's vaccine reactions.
Yep.
Luckily, the only thing I had was an earache so far and a sore arm. But other people have bowel problems, but people with COVID have a lot more problems, and now you have a lot of long COVID.
Yes.
One of my medical students, healthy as anything, graduated a year ago, and she got COVID in Japan. And got over it, came home, graduated, went to her alma mater for like a little reunion with some of her friends, and was in the hospital ICU with diabetic ketoacidosis.
Oh.
Just like that. 2 months post-COVID, long COVID, and she's not a diabetic. She was fine. And she came in to visit with her mother as a physician, and I said, aren't you supposed to be in Colorado now at your residency? And I looked at her mother, aren't you supposed to be in Japan? I just saw you 6 days ago. I had to fly back. She was dying in the hospital. Like, what happened? COVID. I said, was it COVID? That's all they can think of because there's nothing else.
Yeah.
So, all right, so, you get COVID, probably worse than getting a vaccine reaction.
Yep.
I think my son was asking about quarantines. What do you mean quarantines? I said, back in the 40s and the 50s, if you had measles, they put a thing on your house, quarantine, and you couldn't leave the house. You can't do that. I said, yes, you can. People agreed to that in the past. They understood public health.
Absolutely.
Not get the public sick.
The polio vaccine. Yes, there were people who refused it.
I was in class, and I sat in my elementary school. They came in with a little cup with a sugar cube. No parents were there. Nobody said anything. And everybody ate the sugar cube.
Yep.
I'm 73 years old. I have patients that are 79, 80, 81, and I'm checking their legs. I go, oh, did you have a herniated disc or something? Why?
Yeah.
Because your left leg looks atrophied compared to your right. Oh, no, I had a mild case of polio when I was little. And I'm like, yeah, they're a couple years ahead of me. They didn't get the little sugar cube.
Yep.
They had polio. It's amazing how many of my patients
parents had the circle. They had the one inoculation.
Oh yeah, the smallpox vaccine.
Yeah, the smallpox vaccination.
Yeah, right there. Yeah, I all the young kids. They don't even know what that is. I have a 98-year-old patient whose father was a physician who didn't believe in vaccines, and he just scarified her with some acid to make it look like she had a vaccine on her thigh.
Oh no.
Yeah. So there's been anti-vaxxers out there for a long time. Because DOs are sort of conservative with medicine, at least the full philosophy is to be very conservative with medicine. We get a lot of anti-medication docs in the osteopathic field that don't like vaccines, don't like anything.
Yep.
And I said, well, yeah, it's, you want the disease or you don't. I mean,
what's interesting is I had two M2, which is for our audience, those are medical students that are in their second year, and I was talking to them about the early days of inoculation versus vaccination, and how inoculation was not meant to prevent you from getting it. It was meant to lessen the severity of the symptom if you did get it. And, they didn't believe me when I said as late as the 1600s, they were taking patients that were dying of smallpox, literally on a cart around to give inoculations. And they were cutting up the pustule and shoving it underneath the skin. And they didn't believe me, and I had to show them, I don't know if you got to see it, but it was John Adams on HBO. They actually showed the process of them getting the smallpox
Yeah,
inoculation.
I forget her. It was a British woman who her husband was an ambassador to Turkey, and she saw them doing it in Turkey.
Yep.
And brought it back and told the people in England who were a little reticent to believe her. But some Americans picked up on it, so America was one of the first countries to actually take her ideas and do it here.
Yep. You know, there's been a lot of medical innovation in the United States, but we also have some of the loudest people railing against that same innovation at the same time.
You want a new heart? You don't want a new heart.
Yeah.
Then we do carrot, we'll have some...
Carrot and stick.
We'll have a 98-year-old patient. Oh, yeah, but, we can give you a new valve in your heart. And the patient's like, well, it's going to take me how long to get over this? And what are the chances that I'm going to live past 100 to spend all this thousands of dollars to give me a new heart? And I have patients like that, or scientists that go, it's a machine, it's a biological machine, and it has an endpoint.
Yep.
Like you keep trying to, but you're spending all this, financial stuff that taxpayers can you just stop it at a certain point? And,
I make the joke with my mother all the time, because now I'm in my early 30s and the aches and pains are already beginning. I like to say to the younger students, I don't bound out of bed anymore. I groan out of bed.
yeah.
But I looked at my mother and I went, Mom, where's the warranty card? I need it. I need to make sure that I'm covered here.
Yeah, we have, because of chronic pain and things like that, we have a large senior citizen group of patients, and they I forget the one, he couldn't remember where the quote came from, but most say the Betty Davis,
Yep.
old age ain't for sissies.
Mm-hmm.
And then one of them couldn't find the quote of old age is a shipwreck.
Yeah.
But my favorite one of my elderly male patients said, old age, everything hurts, and what doesn't hurt doesn't work.
Yep.
And that's my favorite.
Well, one of our audience members said 30 hit him like a truck.
Yeah, it's like, 23 hit me like a truck. So
I believe it. 25 was like that for me. So I alluded to this earlier in our talk. How did you become a prolific osteopathic manipulative therapist?
in terms of like having children all over the world, or in
terms of you are technically famous.
Technically, it's a technicality.
Yes,
it's a technicality. No, it's like it's in some parts of the world, especially at PCOM. I'm actually infamous. Some don't get my shtick, but no. I've been chair of the Department of Manipulative Medicine at PCOM since 1987. And in that time, the American Osteopathic Association decided that we needed a reference textbook that incorporated some of the allopathic textbooks like Cecil Loeb and Harrison's and Harvey's, which are textbooks of internal medicine and cover the science of what we do and how we look at diseases as the DO physicians, and also include the osteopathic principles and the osteopathic manipulative techniques. And then within the first two editions of that, I thought that other than in a few chapters, nobody was really talking about disease and an osteopathic way of looking at it. So it wasn't really any better than the allopathic textbooks. They were still much better since you weren't very osteopathic. And the techniques were like hodgepodge, awful pictures, a picture here and a description on another page. And I said, we can do better. And I had 3 trimesters a year, 6 trimesters of handouts with all the descriptions, with a photo descriptions, step by step by step by step. So I was in the bookstore, and one of the ladies in the bookstore said, "Oh, did you know that so-and-so publisher is coming here as a rep?" I said, "Really?" She says, "Yeah, for this Foundations book." I said, "Ask her if she's interested in another kind of a book when she comes in." So the woman said, "Sure." So she came up, and I was free that afternoon. So, "What's your idea?" So I gave her like some of my handouts, and she said, "Can I have a couple more? I'm going to take these and put them together." And then a week later, she called and said, "Yeah, the publisher's interested in putting this together and packaging it." So that was 4 editions ago of an Atlas of Osteopathic Technique that's used in, I guess, not all the osteopathic medical schools, but I'd say it's probably 50% of them, because some of them still have their own manuals and all. But it's the textbook that the Europeans use in their courses now, for the American osteopathic courses, etc. And from just being a local PCM doc, I'm now known all around the world for that one book. It's published in, I think, 8 languages now.
Wow.
Yeah, and it was just a handout we gave the students. Now the students are mad because they have to pay for it.
Yep.
Yeah, so it's like, and I'm a wealthy retired doctor because of it.
Oh.
Right, obviously, because I'm sitting here and still working. So it's funny. Some of the students are like, "We have to pay for it," and I'm like, "Excuse me, do you like how little? First of all, this isn't a million copy bestseller novel. You know, this is like a couple hundred books a year that are being sold. You know, 200 and something here, and then maybe another 600 around the world. That's it, 1,000 a year. That's like goes from 1,000 to 10,000 to 100,000 to 1 million. So a million seller novelist, that's the person who has the money. A 1,000 copy person, and they only buy it once every year because they have the book now. However, it is a book that they can use all 4 years of your osteopathic medical education.
And it's probably something that they can utilize for the rest of their practice.
For the rest of their life, because at this point, not too much will change for the average DO that's doing, manipulative medicine in their practice. So it is pretty funny that. But if you told one of my students here, that they just would laugh. They just laugh because I'm pretty, my ego is pretty low.
To echo a sentiment from one of our audience members, I thought doctors were supposed to have 3 houses and a yacht.
No, I just visit people that have those things. The wrong specialty. It's the wrong specialty. I spent too much time talking to my patients, telling them jokes. My first patient, all we did was tell jokes. She was lying there, I treated her, and I asked my student, "Have you heard this joke?" He said, "No." So we told him a new joke. Then I said to her, "Did you hear this joke?" "No." Then she said, "Do you know what shaggy dog jokes are like?" My student said, "No." So she told him 2 long, really stupid shaggy dog stories. I said, "Oh yeah, back in the 70s, they just went on for 10 minutes, and the punchline was like, 'Excuse me.' You just made me sit here for 10 minutes. But that's all we did. So, I have patients that I accused, they only come in to hear my stories and jokes. And other patients don't want to hear any of my stories and jokes.
Yeah.
So you have to know who to tell it to. It's a little tricky. And I think I said earlier before we went on, I'll talk religion and politics to my patients. And it's not that we're having a discussion or an argument about it. It's more from a knowledge base. Really? I'm not familiar with that. How's that go?
Yep.
Really? A patient called me. I was working from home the other day, and they said, "Can you call Mr. So-and-so?" And he's a rabbi. So at the end of the conversation, he said, "Oh, I thought you called me back, that you would want to know something rabbinical." And I said, "No, I wasn't thinking that way. But now that you mentioned it, in Judaism, I was very surprised. Am I correct that the Reform aspect of Judaism is more modern or is older than the conservative group?" He said, "That's right." And I was like, didn't seem right to me. But, so then we had a whole discourse on Reform versus conservative versus Orthodox Judaism, and he's teaching me all about Judaism. And I'm like, okay, now, you're not supposed to do that.
No.
But it was so he taught me a lot about Judaism that I didn't know, because I come from a Greek Orthodox family, and I was like,
well, we can't all be perfect.
no.
One of the things that my father taught my brother and I is that you can't be closed-minded. Closed-mindedness is what has caused the majority of the problems in history. And my father always said that you should always be inquisitive about what you don't know. And if you have questions that you can't answer on your own, you have to go to the expert in order to get the answer. So you can't just go to Joe Schmo off the street and say, "Do you understand this major concept?" You go to a person who works in that field and you ask them the questions. So I agree with you 100%. I have always asked questions about different religions, different politics. I've always tried to understand it, because in understanding I find I am less extreme in my views. I find that my views are much more mild in general. And in terms of health, I find that, my stress level in terms of those topics is much lower as well.
Yeah, you find out no matter whether it's you live on a mountaintop or a valley or a desert or a jungle, or you speak this language or that language or this religion or that religion, you just get deeper and deeper and deeper and deeper. There's a lot more similarities than there are differences, and the differences are just, local, could be geographic, it could just be somebody 1,000 years ago thought one way and everybody followed them. And if you strip that away and say, well, in your little household, what do you tell your kids? Because I have a lot of friends now, so I'll stay in their house for a couple days and visit my friends, and I'll watch how they talk to their kids and watch how they interact with their children about their grades in school. And did you do that? And I'm like, oh my God, they're speaking in German, but they're doing exactly what I do with my kids.
Yep.
And their house is kind of like my house, and other than their language, they're no different than me at all. It's kind of.
No, you're absolutely right, and I'm kind of getting in a weird way around the topic that I'm trying to bring us to, which was a similar thing that I did with Dr. Goldstein, but one of our audience members actually asked a good question here. Have you ever experienced any of those human library events?
A human library event.
You know what I'm talking about.
No.
It's when they have, generally it's elderly, but it's people who have had experiences, and you can check them out and have a conversation with them about their life and what they've experienced.
Oh, yeah. As a matter of fact, I tell my students that I'm not and never have been particularly been interested in pediatrics because I can't learn anything from the patient other than their medical condition.
Yeah.
So I like a patient that I can help that teaches me something.
Yeah.
And has some experience that I've been thinking about. Or one of my patients who passed away a few years ago, I met him originally as his new patient visit with me in 1979 when my wife brought my son in for his 1-week pediatric appointment here and brought him to our offices to show his, the grandfather who was in my department and my colleague and my secretary. And he happened to be my new patient. And for the next 30-some years, this very educated, very successful president of an insurance company was my mentor, was my patient mentor. Whatever I wanted to know about politics, life, business, finance, investments, how to budget this, where should I go for this, he would tell me how to do it. And then for medicine and other things, it was my 2-3 older colleagues. Yeah. So I had, and if I could just list, which I can't say their names, like 80-some years old, 90 years old, 80, 70, 90 something, all just, I just took everything they could tell me from their experience and learn from it. And I was like that as a kid. Always hung around the old people. Yep. And some people just don't like to do that, but they're so funny. I mean, they're just like, and to listen to them, I can tell you a really humorous story. One of my patients had a hearing problem, and some people that have hearing problems speak very loudly. So when you first met this woman, you were like, oh my God, this woman just, oh. But as you got to know her, you realize she just spoke loudly because she couldn't hear. Yeah. She was this wonderful, caring, charitable person that taught kids and fostered kids and this. So she was out with my secretaries. We went and took her out after the visit, and she told the secretaries it was her 65th wedding anniversary. Oh my. And my secretaries, really? And she's screaming, yes, and we're going here in this very loud voice. And her husband was standing looking out the windows with a magazine. And I went about 3 feet from him to get a cup of water out of our water cooler, and he didn't see me like 3-4 feet away. And I see him take this magazine, and he flipped the page, and she went, yes, 65 years, blah, blah, blah. And he looked at the page, he looked out the window, and he said, 65 years, and no end in sight. And then he went and started reading the page, and I just thought that was so cool. I just wanted to say that when I'm 80-some years old and say that about my wife and go, because he loved this woman so much. And it was that voice, if I could just get that voice to tone down. It was so adorable, and they were just a lovely couple, and I just so that's the I find I used to go out to lunch once every 3 months with 2 patients that were like 35 years older than me, and they were friends, And all my second, why do you go out with Mr. So-and-so and Mr. So-and-so? I said, because I like them, but they're so much older than you. They're older than your father. I said, but they teach me so much. I said, do you realize that Mr. So-and-so on Friday nights used to play poker with Eugene Ormandy, Freddie Mann of the Mann Center, and so-and-so and so-and-so? And the stories I get, like Eugene Ormandy, Freddie, all these big Philadelphia people, and he can tell me all these inside stories. And the other guy's a consul for this, and he speaks French and German and knows everything about wine, cooking, philosophy. The smartest guy you've ever met in your life, recites poetry. I told him how I was learning the poem Gunga Din by Rudyard Kipling, because I was going to recite it to my sister-in-law, who always we'd go out to dinner in the summer, and I'd order a gin and tonic. And she would go, you talk of gin and beer when you're quartered safe out here, and you're sent to penny fights and older and she'd stop. And I go, what's that? Gunga Din. I said, well, keep going. That's all I know. And she did this for years, which was aggravating me. So at her surprise birthday party, your husband was having it at my house, and I only knew 3 people coming. The rest were total strangers. I took a chance, and I got a desert, British Indian desert outfit, and I printed it out in a scroll and had it wrapped up. And I got the movie Gunga Din from the late 30s, put it on my video cassette with my wife's girlfriend, who happened to be there, setting it up for me. And I came down with a steamed off flavor of a Sam Adams beer, so it looked brown. And I came down, she pushed the button, and you hear the bagpipes going, this and that, hand her the thing, and she's, what? And everybody's looking at me, and nobody really knows me except for 2 other people. And I recited the whole poem for her finally. So I'm telling this one of my lunch buddies this, and he said, oh, Gunga Din, Rudyard Kipling, excellent poem, and recited at 83 years old the entire poem. He goes, and Rudyard Kipling for a while was one of the most quoted men in the English language. And then he recited On the Road to Mandalay. And then he said, but I really prefer Elizabethan sonnets, and then recited an Elizabethan sonnet at 83 years old. And I turned to my student Emily, who was a Bryn Mawr grad, really smart woman. I went, what is going on? I've been trying to learn this thing for a week and a half, and he's just spouting this stuff off. And I said, that's why I go to lunch with these guys. There's just people that surprise the heck out of you.
There's a certain beauty to it.
Yeah. And the other part, as a physician, like when you're a physician in a hospital, or let's say a medical student, more than physician. Let's say you have an 84-year-old patient that's sick as a dog with pneumonia. And they're like, oh, well, he's this, I said, now take a breath and don't start acting like this person's going to die, because with the proper antibiotics and fluids, etc., he'll be back on the golf course in a week, because he just played 36 holes of golf in the last 3 days and walked half of it. You think he's this innate, this fragile little person that's ready to die. No, this guy's an animal. He's out there like they just happen to get sick. Don't just because he's 83, don't put him in the pasture here, or don't bury him. Oh my God. And it's so easy to do that with elderly patients. And they're just, some of them are feisty. They refuse to go.
I mean, when you saying that, I'm reminded of Eisenhower when he had, I believe it was open heart surgery, and they had him out on the golf course. I think it was the next day, and that was to help his recovery. They said, just do us a favor, don't take the cart, walk the whole way. And I think he was back in action within a week.
Yeah. He was an interesting guy too. Now he's looked at as a really excellent president. And before he was just, he's an okay president. The 50s were just easy, Well, maybe the 50s were easy
really.
to be the president.
So I want to get your opinion on this. And when Dr. Goldstein was here, I asked him a very similar question. Are you familiar with Hunter Doherty Adams?
Hunter Doherty Adams, no.
He is more commonly known as Patch Adams.
Oh, absolutely. He lectured here years ago.
I did not know that.
Yeah.
What do you feel about his methodology of interjecting humor and joy and laughter into medicine as a therapeutic?
That's all I do. As a matter of fact, he recited a poem by Walt Whitman, I think. And I said to my associate, Dr. Heilig, you wouldn't let me do Gunga Din for the students so I could do it in front of an audience. Because you said they were really, I said, this guy's famous and they're loving him, but I can't do it? He goes,
technically you're famous too.
Well, not now, yeah. I'm not Patch Adams. I do card tricks and I juggle a little bit, and I can rip phone books in half if I practice a little bit. But yeah, I mean, I can get in trouble with my sense of humor in today's world. That's the other thing. You have to be really careful today. You can look at the student in class, and you're just looking at, some student thinks you're looking at them in the wrong way or something.
Yeah.
It's just, little funny stories that I told 15, 20 years ago, 100% hysterical reaction. Today, you could get reported for it. So it's really, it's a little disheartening.
We've grown as a society, but we've also become very sensitive as a society. Lately, at least, it seems. Well, anyway, that brings me to the main topic, and I do apologize. It is 6:03, and I want to respect your time. As I always remind our audience, this is the end of the workday, and you're doing this on your own time, and we greatly appreciate that.
My pleasure.
How important has empathy been in medicine since you started as a student to now in your current practice? How has empathy been interjected, been used as a methodology for connecting with the patient and as almost a way of generating a therapy for the patient?
Well, in terms of a teacher, for 48 years now, if you can't show the patient that you're sincerely understanding of their condition and taking it very seriously, then you have a problem. The patient has to know that you're absolutely involved in their situation. And some patients actually make it difficult. We were just talking yesterday about a new patient, and I interviewed her with a student, and I said, "Oh, you're from this region your whole life?" "No." "Where are you from?" "What's that have to do with my visit?" And I said, "Well, I'm trying to get to know who you are, so that when you come back, I'll know you. I'll know everything about you." "Well, I'm from New Jersey." I said, "Where about?" "Why do you need to know where And I just, North Jersey. "What brought you down?" And every time it was a big huff. "My husband's job." "How long have you been here?" "Oh my God." "Do you have children?" "Yes, I have 2 children." Where do they go to school?" "What do my children school after?" "I'm just trying to get to know you, get a feel you." "Oh, they go to this school." Third-year student says, "Oh, that's where I went." She goes, "Really? Was it a good school? Did you like it?" "Oh yeah, it was a private school." Says, "Matter of fact, my mother teaches there." "Really? What does she teach?" "Elementary education." "Oh, well, I have a second and a third or second and a fourth year student there." "What's your mother's name?" "Mrs. So-and-so." "Oh my God, that's my daughter's teacher." See now I'll never forget you. And she just and she still wasn't happy about it. She was so trained to just talk about my disease. I said, "No, I'm trying to learn every single thing I can learn about you right from the get-go, so that when I had a patient that I hadn't seen him for 5 years, and I looked at him, I said, today, I said, so let me get this right now. We saw you for your back, and you went to so-and-so high school, and then you went to Vermont, right? He's like, "Vermont? How did you remember that?" I said, "That's how I do it." I said, "My brother, who's a physician, same way. Where are you from? Where'd you go to high school? Where'd you play football? What'd you do?"
Yep.
And it's just every single thing, because now, if you go to a movie and you walk out of a movie and you start telling your friends all about the movie, right? It was entertaining, so if I can make it entertaining for myself, I'll remember everything about you.
Exactly.
And when you call me up on the phone and it's late at night, another patient call, "Oh, Miss Sosa, how you doing? What's going on?"
Yep.
And then I have patients of associates, when I was on call, they'll call when I'm on call, because I'm the one that'll talk to them. "What are you doing, Paige? Why you call me at 2 a.m? "I'm watching the Eddie Murphy movie." Blah, blah, blah. And my wife, I hang up. My wife goes, "Who was that?" And "Why would you talk to her like that? You were having fun. It's 3 a.m. I said, "She's an old lady. She's wide awake. This is what I do. It's not this. I am the complaint department."
Yeah.
I took a job where I hear everybody's complaint. What is it about medicine? The first question you start with is usually about their kid. What is your chief complaint?
Yeah.
Right? I said, so it's not like people nag. That's what they're going to do. So you have to understand that you don't take that negatively, and then you have to respond that you're attentive, that you're caring, and some days, I try. I think one time I had a patient get to me where I just couldn't deal with it anymore because she wanted me to do something to her that I thought was inappropriate. And I said, I can't do it. I need to get x-rays, I need to do this. And it's unsafe, and I won't do it. And she stormed out, cursing at me. And her daughter's like, I'm so sorry, because her daughter and son-in-law are patients of mine. And the student looked at me and said, she's going to curse me all the way down the hall. But I'm not doing it, because it's not professionally indicated. And I can't do it, it's not safe for her. And she, I could kill her with it,
Yeah.
And that was about it. I started to lose it with her. But usually I'm pretty good with most of my patients. And I do, I patch Adams it. There are doctors that he got real famous for it because he had a shtick.
Yeah.
I know a lot of doctors. A lot of my mentors, like I'd go into the cardiac care floor, and he taught me how to do card tricks for them and juggle for them, and do things that we used to do were crazy in those days.
When I was in elementary school, kindergarten was half a day. When I was in elementary school,
Right.
I don't know if it's still that same way.
Yeah. Then you can have extended programs, but it's largely still half in most districts.
I went to the Y afterwards. There was a after school and after
my
kindergarten
grandchildren
thing.
are doing that now. One of the local gyms they have after school.
You remember the bases of lampposts where they were that sharp box? Well, I wasn't watching what I was doing. I was playing with friends, and I fell backwards, and I hit my head. And it split my skull open.
Right.
And I remember at first I didn't feel anything, and I really didn't feel a thing.
Yeah.
There's not much in the way of nerve in there to really.
It bleeds though.
It bleeds. Oh God, was it a bleeder? And I remember my family doctor, who, like I said, was an MD, and all he's doing the whole time. My parents are like, "Oh, is he going to be okay?" He's ignoring them. He's just having a conversation with me as he's sewing up my head. Just everything's fine. I'm just going to have a conversation with the young man in front of me to take his mind off of what is actually going on. I don't even think he used an anesthetic on me.
Yeah.
I don't think he even needed to.
I've hit my head in the same spot where you're kind of close to you 3 times, and I haven't had anesthesia at all ever for three suturings. I'm like, it's like, another one. But yeah, it's like the parents are all going crazy. But my son had a lesion on his back, and the dermatologist said, "Do you want this off?" And my son said, "He said because it could be. It's right now. It's okay, but it could get bad years from now. So you want to get it off now?" My son said, "Get rid of it." And then the whole time he just kidded around with my son. Yep. Dum, and did his business. And it's they don't say medicine is an art and a science for nothing.
Yeah.
And once one of my students in a lecture called me on that. This is a science. How can you say it's an art and a science? I said, well, talk to me in 30 years.
Yep.
And you have a patient in front of you, and they're giving you a history. They look like somebody else that you saw years before, and they had the same kind of complaint. And you say, you have to have this blood work and this MRI and this. And you go, okay. Then you call the doctor that referred them to you and said, this patient, I think they have a tumor or they have multiple myeloma or something's not good. And we get the results 2-3 days later, and the doctor calls me back. How did you do that on a history and a physical? I said, because I've had 3 patients like this. Yeah. And this one was like, there's something very familiar. And it's just, that's the art. There's nothing, it's just experience.
You're very right. And even in research in science is very much an art form because there's nuance to the technique. I fully believe, and this is one of the reasons why I wanted to make this content, is because I fully believe that anybody can do science. Anyone can do scientific research. If given the time and the willingness, anybody can do it. It's not really hard. There's certain aspects to it that you can learn with experience, which is kind of what early medicine was. You were walking around with the physician, learning from him by experience. And that's really what it is.
Yeah, preceptorial.
And I had a discussion with a couple of forensic students today, and I said, listen, This protocol has been done for generations. This is one of those protocols. It was immunohistochemistry, so staining of slides. And it's been done since the early 1900s. You can still make a mistake. And it can be something as simple as you press down way too hard on the plunger of a pipette. Something as simple as that. And you won't know that until you get the experience.
Right.
So making a mistake, it's an art form. If it was what we term commonly, like it's a science, it would perform the exact same way no matter what you did every single time. And I like it that way. I like that it can have those nuances. Yes, it's frustrating. Don't get me wrong. Research science has been one of the most frustrating things I've ever done in my life. But it's also been one of the most rewarding things that I've ever done for those aha moments. And I love, as an instructor, as a mentor, as a teacher, being able to see that moment in a student. And that has always brought me such intense joy for that. When it's a PhD student, I'll generally grab them by the shoulders and go, hold on to this, because you'll need it for the next 6 years. Because they're just going to be doing the same mundane thing over and over again.
Yeah, some people have an innate, like just like making a slide and staining it. Because one of my patients is a former biology professor at a university, and when my daughter was doing some post-bac work, she became her lab assistant. And she said, there must be something genetically, kinesthetically, manual kinesthetic talent that's genetic, because your daughter came in and I showed her how to make these slides of the pineal gland. And she just went, and they're gorgeous. And she was in a few weeks ago. I was looking at these slides and I'm like, oh my God, these slides are gorgeous. When were these slides? Veronica Nicholas, honest to God. She said it was her slides again 20 years later.
Yep.
Unreal. She said the best. She just did it. It was unbelievable. It was just uncanny how she did it. So she just has the innate art form of just knowing how to do it innately. Some people have it. Some people have to learn it. It's like when I was kidding around about being a singer. At 73 years old, I just saw something yesterday by a vocal instructor. And some people have an innately good timbre in their voice, and it vibrates a certain way. But if you work at it, you can actually learn to sing.
Yeah.
And I went, now you tell me.
I have gotten to know some very brilliant people in my short lifetime, and I've watched a mathematician friend of mine write out a proof off the top of his head, and if you had no training in math, it would look like absolute gibberish. But I was following where he was going with it, and I was, he got down to the very end, and then he groaned and he erased the whole thing because he had made one small mistake. And I've seen, Harvard professors who think that they are the greatest thing in the world, and you look at them and it's like, oh God, they made that one mistake 20 years ago, and they still think that they did it absolutely right, and no one will ever be able to tell them otherwise. And I've always been a firm believer, it doesn't matter where you got your education, it matters what you did with it.
Oh, yeah.
I said earlier that it was 6 o'clock. It's 6:16 right now, and I don't want to keep you all night, even though it seems like we could go all year with this kind of conversation.
Do a part 2.
Absolutely. I want to welcome you back at any time that you would like. Please join us again. We would love to have you. While I give our audience any time to come up with some final questions,
Sure.
Do you have any questions for me that you would like to ask?
No, I just the questions I had, like Patch Adams and his full name, I couldn't remember. Yeah, so you've explained anything that I didn't know. I was like, wow, a lot I don't know here.
What was it? Out of the mouths of babes comes the wisdom of the universe. So, you never know where that.
Yeah. Well, I have grandchildren and children, so I've heard some crazy ones.
Mm-hmm. Yeah. No, next time we'll ask about your evening routine. Well, Dr. Nicholas, thank you so very much donating some of your time to us. I really do appreciate it. I I like to offer this moment for our guests to be able to say whatever they'd like. The floor is yours. The floor and the microphone are yours.
Oh, wow. Well, thanks for having me, and thanks for the audience participation and questions. It's because I've been doing this, for so long, and my father was also a DO, and so historically, just growing up, I didn't know my father was a DO. I thought all doctors did what he did. Then I was shocked to find out that all the other doctors in the neighborhood didn't do what he did. And he was pretty well known, and he was not just osteopathic manipulative medicine general practice, but he was a team physician for a lot of the Villanova football, basketball, track teams from 1946 to 1960.
Wow.
Matter of fact, he was on a train going to the Texas A&M when I was born. So my mother wasn't so happy. So he was the team physician, but he treated, I think, 9 Olympic athletes, medal winners, really famous, track stars at the Villanova, football players, famous basketball players. And I think in high school I found out he was a DO, that he wasn't an MD. And because the health instructor was telling everyone about certain things, and you can only get this from MDs, you can't get this from a DO, osteopaths can't treat for medicine, can't. And about 20 guys in the class, in the health class, just looked at me and went, "What?" I go, "Your father gave me a flu shot. Your father did this. Oh my God." So I told my father, and he went to the school board and the superintendent, and that teacher got in a lot of trouble for spreading false statements about osteopathic medicine. So I've seen like the anti-osteopathic, but the last 20 years of my practice is like allopathic or MD physicians and osteopathic physicians. I have really good friends on both sides, and I have allopathic MD docs that seem more osteopathic than the osteopathic physicians. So it's just...
Didn't I see that the certification groups are now starting to merge?
ACGME's all merged now. So, my daughter's a DO and did her residency in obstetrics at an allopathic MD institution, which is mixed now. Most of them are just mixed staff. So all that's just ancient. And if there's any anti-osteopathic philosophy or beliefs in the MD profession, it's usually from people that have no idea what we really do. Yeah. Because some of my patients have been chiefs at the major allopathic MD medical schools here, and yet their underlings are, dissing the osteopathic profession. And I said, "You guys want to talk to your chief because he's my patient." And it's still a minority profession in terms of numbers. So a lot of people don't know, and because we are physicians, our graduates can be psychiatrists, so they're not going to be touching a lot of patients. So I said radiologists. They're going to be in like surgical fields, like my daughter, who's just too busy to do it. Once she called me up and said, "Guess what I did today?" And I went, "Whoopee-doo." Yeah. Because I said, once in 10 years. She said, "But Dad, I don't have the time." I said, So it's just, but it's a very, it's a warm and comforting type of practice, because you do, your patients, especially if they're chronic patients, they sort of become friends and family members, which I saw from my dad. They were all, and he was in private practice for a long time, and he couldn't charge some of his patients anymore because he was just too friendly with them. So what they would do is they'd do something for him, and he'd do something for them, and we have. I remember one of my father's patients we called Larry Bang Bang. He was at work. Because of an injury, and my father got him back to work, like for 6 months, treated him, and he finally got back to work, and he never charged him because he didn't have any money. And my father wanted our basement refinished, so my father bought all the material, and Larry Bang Bang, my youngest brother's intellectually challenged, and he used to hear him hammer, so he called him Larry Bang Bang. And at my father's funeral, this guy came up to me, and as he was walking up to the casket, and he was crying hysterically. And I looked at him because I hadn't seen him in 25 years, and I just went, "Larry Bang Bang!" just started crying and hugging this guy. And that's the kind of patience my father had.
Yeah.
So I got stuck kind of being that way too, because it was habituating, you know.
Yeah.
It was almost narcotic to have that type of relay. You know, it's a good kind of narcotic, where you feel like you're part of a larger community, that we're all related.
Yeah.
You know.
No, I if I may, I had a similar situation when my father passed. There was so many people that showed up for his viewing that we actually had to have a second viewing and a third viewing at the church. And then we had to, you know, I couldn't believe how many people were in the church proper. You know, I didn't really get to notice it, but a friend of ours took video of it because someone couldn't make it, and it was almost full. And our parish was large, and must have been we could probably fit at least 1,500 people in there, and it nearly filled
Wow.
that church, and it blew my mind that so many people were connected to my father.
Yeah, he affected a lot of people, evidently. Yeah.
It's very interesting, but thank you so much,
My
Dr.
pleasure.
Nicholas. I really do appreciate it. You are absolutely welcome to come back.
Just let me know.
Of course.
If you have a void in your
probably-
schedule, I'll show up.
There's probably like 8 or 9 other questions we could probably talk about, lymphatic drainage and things like that.
That's it.
Absolutely wonderful. So let me take us home, and we'll all be able to go enjoy a nice dinner with our families.
Okay. Thanks again.
I want to thank you all for joining us tonight. I know I had fun, so I hope you guys did too. If you enjoyed this, I hope you will consider following us, as that way you'll be notified when we will be doing this again. Also join the Discord, as that is where I put all of the information regarding this, and we also have a separate topic. So if you do come up with a question for one of our guests after the fact, feel free to put it in there, and I will relay it to them and then get you an answer as soon as I can. Subscriptions also help, but as I always say, it's never something that is required. Thank you guys so much for joining us. So long, everybody. Thanks for all the fish. Bye-bye now.